Thank you all for joining us today for the first Primary Health and Retirement Subcommittee hearing on mental health and behavioral health for the 118th Congress. Thank you to Senator Marshall for your shared commitment to addressing the mental health and substance use crisis in the United States. There are many people at home who will watch this hearing and recognize the realities they face every day. They call for help and are met with long wait times or an hour-long commute to care. They have lost a friend or loved one to mental illness or substance use disorder. But support and services aren't accessible. They know when they need help, but they don't know where to go to get it. Let me start by saying you are not alone. The reason we are here today is to identify those challenges and chart a path towards a future where help is there when you need it. On the Senate Health, Education, Labor, and Pensions Committee, it is our responsibility to take up the fight for a better mental health and substance use disorder care system that meets people where they are with dignity. But today, we are losing that fight. Last year, over 106,000 people died from an overdose. The CDC reported just last week that overdose deaths involving fentanyl had more than tripled in the last 5 years. Emergency department visits for opioid-related overdoses increased by 41% for boys and 10% for girls aged 12 to 17 in the fall of 2022 compared to the year before. And yet, 94% of people aged 12 and older with substance use disorders did not receive treatment. The prospects for people facing mental health challenges are equally distressing. More than 1 in 5 adults in the United States has a mental health disability. Yet, over 10 million people report an unmet need for mental health services. 1 in 5 high schoolers have seriously considered attempting suicide. For LGBTQ youth, the number was closer to 1 in 2. Yet, over 2 million adolescents who needed care did not receive it. The cause is complex. Pharmaceutical companies supercharged an opioid epidemic by overprescribing OxyContin, ultimately hooking people on heroin and fentanyl. Big tech serves toxic content that grabs young people's attention and fuels depression, anxiety, and eating disorders. Childhood trauma and toxic stress linked to violence, poverty, racism, and housing instability create invisible scars that weigh heavily on caregivers, children, and seniors. And as a growing number of people experience mental health conditions, our health system has not been able to keep up. People are looking for an open door to care, and instead they are locked out. But these invisible scars continue to grow, and thousands of people find themselves in the emergency departments hoping for placement in treatment programs. Or they leave, and without anywhere to go, we lose them to suicide and overdose. So yes, the challenges are complex, but the solution is simple: affordable, accessible mental and substance use care for any and all that need it, when they need it, and where they need it. This is easier said than done. But there is hope to be found in the everyday heroes who have rolled up their sleeves, looked into people's eyes, and offered a helping hand. A few of those people are with us today: addiction medicine physicians, child psychiatrists, and providers from community health centers and certified community behavioral health clinics. They are the better angels of our healthcare system, and right now we need an army of angels. We can build a system that treats people with dignity and doesn't price patients out of the care. We can invest in community health providers. We can pass legislation to break down antiquated barriers to medication, treatment for opioid use disorder. We can support local communities' public health response to rising overdoses and mental health needs. And we can make sure that Big Pharma doesn't charge big bucks for life-saving prescriptions. We can create a system that puts patients over profits. So I'm proud that so many of our fiercest advocates for these efforts are in this room today, and we thank you for all of your work. And with that, I turn to the ranking member, Senator Marshall, for his opening statement.
Well, thank you, Mr. Chairman. I also want to appreciate your dedication to addressing the mental health crisis and for holding our first subcommittee hearing. I know our colleagues on both sides of the aisle are interested in reauthorizing several expiring programs. we also want to look for new ways to tackle this crisis. Our witnesses today will show us how they are using existing federal programs and their own ingenuity to reshape their communities. It's been 5 years since Congress passed the Support for Patients and Community Act, the largest, most comprehensive legislative package that directs federal resources and statutory changes towards prevention, treatment, and recovery. The Support Act encouraged payers and providers to utilize alternative treatments for pain. It increased patient education and awareness across many markets, modernizing prescribing to detect and prevent fraudulent prescriptions, expanded safe disposals of unused prescription drugs, including at-home deactivation packets, and finally, it helped people get on the road to recovery through various inpatient and outpatient services. Let's talk about prevention first, where we're seeing great progress. Notably, substance use disorder and related deaths as a result of prescription opioids are decreasing because physicians and nurses are increasing patient awareness and utilizing other treatments for pain. However, Chairman Markey and I in this committee, our aim is to prevent addiction by moving away from addictive medicines. The Support Act required the FDA to help address biopharmaceutical challenges in developing non-addictive pain therapies, but the agency has not successfully carried this out. We will hold the FDA accountable so patients can one day have access to innovative, non-addictive prescription drugs. On treatment, we'll hear from our witnesses on the successes of expanded access to medication-assisted treatment, telehealth, and novel coordinated care models, including certified community behavioral health clinics, or CCBHCs, which I'm a very strong advocate for. We've all witnessed too many people experiencing a mental health crisis in the wrong setting and receiving the wrong type of care. While still new, the data looks promising. People who receive care at a CCBHC spend 60% less time in jail, 72% less time in the hospital, and are much more likely to have access to a primary care provider. CCBHCs also contributed to a 41% reduction in homelessness. Congratulations, and I'll look forward to Mr. Denny's testimony to share some more of those stats again. For all the good our witnesses are providing, Congress must work to ensure that they can deliver timely access to care by addressing mental health parity issues. They need our help to eliminate unnecessary delays and denials from prior authorization, the #1 administrative burden across all clinicians and other healthcare providers. On recovery, the Support Act provided peer recovery support services and other programs that are helping people help themselves to become independent, stable, and healthy. In addition to the Support Act, I hope this committee will work with us on developing solutions to address some of the root causes of the mental health crisis in America's youth. Due to the lockdowns and resulting isolation, kids increase their reliance on social media, shifting their habits beyond a casual pastime. In fact, experts have found that overuse of social media rewires their brains to constantly seek out immediate gratification. This leads to obsessive, compulsive, and addictive behaviors. Studies have linked heavy social media use and increased risk for depression, anxiety, loneliness, self-harm, and even suicide ideation. This year, the CDC released a new survey finding that nearly 60% of young girls reported a mental health issue, with 30% seriously considering suicide, double the rate that was among boys, and up to almost 60% from a decade ago. We know social media companies are aware of this based upon their own similar findings. There's no silver bullet in solving the mental crisis. We must continue to bolster efforts on prevention, treatment, and recovery. In doing so, we should value what we measure and measure what we value. As we consider reauthoring expiring programs and exploring new ideas, they should be patient-centered, outcome-driven, cost-effective, and they must be backed by data. Mr. Chairman, thank you again for calling this hearing, and I yield back.
Thank you, Senator, so much. And we'll turn to our first witness, Dr. Maria Chelli, a psychologist and the Deputy CEO of Brockton Neighborhood Health Center in Brockton, Massachusetts. She has worked at the Brockton Neighborhood Health Center since 2016 and has worked in community health centers since 2010. Dr. Chelli launched the Brockton Behavioral Health Task Force to promote collaboration between behavioral health providers across the city's behavioral health and substance use services ecosystem. Welcome, Doctor. Whenever you're ready, please begin.
Good morning, Chairman Markey, Ranking Member Marshall, and members of the committee. Thank you for the opportunity to testify on the critical topic of mental health and substance use disorders and access to community-based prevention and services. As Senator Markey noted, my name is Chelli, and I'm a psychologist and the Deputy CEO at Brockton Neighborhood Health Center, a federally qualified health center located in Brockton, Massachusetts. In my role, I have witnessed the negative impact that the pandemic has had on the mental health of our patients and the community. The demand for behavioral health services is enormous, outstripping our community-wide supply of resources. This morning, I'm coming on behalf of our providers and patients I have the privilege to serve to propose 4 opportunities for support to improve community-level access to behavioral health and substance use disorder services. Those 4 are increasing support for integrated care team models, leveraging mobile medical units and continued use of telehealth services, including audio-only services when appropriate, prioritizing pediatrics, and workforce development and wellness. Like many other community health centers across the country, Brockton Neighborhood Health Center employs integrated multidisciplinary teams to serve patients holistically. That means we address everything from food insecurity and housing insecurity to disease management. Our patients are universally screened for health-related social needs, depression, and risky substance use. We make screening for mental health and substance use disorder a standard part of primary care. By doing so, we reduce stigma and create easy and seamless access to mental health and addiction services. Additionally, we have found that primary care behavioral health integrated teams can reduce costs to the medical system, and I'll give one example. Recently, we had a 21-year-old male who was new to our adult medical department. This individual had significant medical complications and was in and out of the hospital frequently, very frequently, like 7 times in a couple of weeks. Concerned about his mental status, the primary care provider at BNHC engaged one of the integrated behavioral health clinicians who was able to meet with this individual and begin to build trust. Since the team of the integrated primary care, the integrated clinician and the primary care provider have started to work with this patient, he has significantly reduced his emergency room visits and has begun to make good progress with his medical care. Additionally, in addition to primary care behavioral health integrated models of care, I propose increasing access through mobile units and telehealth services. We have found at Brockton Neighborhood Health Center through our first mobile unit that this is an effective way to reach vulnerable populations, and I'll highlight 3 in particular. So in 2020, Brockton Neighborhood Health Center leveraged grant funding to launch our first mobile unit, which provides services specifically to those experiencing homelessness and people who use drugs. We have observed that overdose deaths have increased significantly in our town, and nationally that's the same. The services on this mobile unit have undoubtedly saved lives. However, we've also observed a rise in mental health needs in both pediatrics and seniors within our community. That is why Brockton Neighborhood Health Center is working hard to acquire mobile units that can be deployed to provide integrated care at schools, at senior housing sites, et cetera, to meet our patients in the community that has the need where they are. I'm so appreciative that last year, this committee recognized the value of mobile care units when it passed the Mobile Health Care Act by unanimous consent to make it easier for health centers to finance mobile health units. Additional new access point funding will help health centers like ours take advantage of this opportunity to create easier access to patients who need it. In addition to launching the mobile clinical units, leveraging strategic use of telehealth is essential to address this crisis, and I strongly support permanently extending the telehealth flexibilities implemented during the COVID-19 public health emergency. Of course, none of our work in addressing this crisis is possible without robust and well staffing. BNHC has designed and launched a number of grant-funded professional pipeline projects, including one designed for the training, recruitment, and retention of behavioral health clinicians. We would love for this committee to provide more flexible funding to support projects like ours. Another priority for our workforce is wellness programming to mitigate employment-related stress. I appreciate that last year the HELP Committee passed the Lorna Breen Act, which authorized funding for provider burnout, and we genuinely appreciate any support that our staff can receive to remain well in these roles as they continue to work daily to save lives. Health centers like Brockton Neighborhood Health Center need long-term sustainable and predictable funding to continue to address this behavioral health and substance use disorder crisis. Chairman Markey, Ranking Member Marshall, and members of the committee, thank you for allowing me to share some of the great work that my team at BNHC is doing to fight the mental health and substance use disorder crisis in this country. With this committee's support, we will continue to find new ways to provide affordable, accessible, and high-quality care to the communities we serve. And I look forward to your questions.
Thank you, Dr. Chelli, so much. Now, Senator Marshall will introduce our next witness.
Well, thank you, Mr. Chairman. I'm certainly honored to introduce our second witness, Mr. Stephen Denny, a fellow Jayhawk and a multi-generational Kansan. Mr. Denny is the Deputy Director of the 4-County Mental Health Center. Their main office is in Independence, Kansas, and they proudly serve 5 counties now across southeastern Kansas, including Montgomery, Cowley, Wilson, Elk, and Chautauqua. As I think about that, that's probably an area of about 100 miles by 70 miles, very sparsely populated, and probably it is the most economically challenged portion of Kansas. In addition to serving the Mental Health Center, Mr. Denny is also the project director of 4 Counties Certified Community Behavioral Health Clinic Expansion Grant, provided by the U.S. Substance Abuse and Mental Health Services Administration. Under this role, Mr. Denny oversees clinical crisis and substance use treatment services, as well as seeing patients every day. Thank you so much for agreeing to testify in person, discuss the work being done at 4 County. Mr. Denny, the floor is yours. Thank you.
Chairman Markey and Senator Marshall, thank you so much for this opportunity to testify before the Senate Help Committee this morning. As mentioned, my name is Steve Denny. I serve as Deputy Director at 4 County Mental Health Center, serving 5 counties in southeast Kansas. You'll hear me refer to our organization as 4 County throughout this testimony. As mentioned, I'm also the Certified Community Behavioral Health Clinic Project Director, also known as CCBHC. We were the first Kansas organization awarded a SAMHSA CCBHC expansion grant in May of 2020. Since then, 6 additional centers have followed suit in 2021, and by July 1st of 2024, all Kansas community mental health centers will have the same opportunity to become CCBHCs after the passage of Kansas House Bill 2208. It is a true honor today to speak to you about this exciting opportunity and what it has done for our state and our nation. The second C in CCBHC stands for community. My community is Montgomery County, Kansas. It's a rural Kansas county located on the Oklahoma border. It contains both industry and agriculture. My hometown is a place that I swore I would never return to when I went away to college, and I've been back now for 18 years. My father's a lifelong rancher. My children are the 6th generation to live on our family property, our small farm. My community matters to me. The CCBHC model requires 9 core services that are oriented around the unique needs of each community served by CCBHCs. Those 9 services are included in my written testimony for further review. This community focus, combined with the comprehensive care, data-driven measures, and a continuous focus on quality improvement, is what makes the CCBHC model such a game changer. I've worked in this field since 2002 as a therapist and a supervisor of multiple populations. During this time, our field has experienced funding cuts, reduction of inpatient resources, and a state hospital crisis that's brought our system to a breaking point. Many of my colleagues have left the field for less demanding jobs that often pay more. Meanwhile, the needs of our communities continue to grow, leading to this crisis. CCBHC has served as a lifeline for our system. Kansas House Bill 2208 provided foundation for our state to apply for the recent CCBHC planning grant to expand this model with the support of Senator Marshall, for which we are immensely thankful. One shining example of an expanded program under our model is our Veteran Services Program. This provides specialized care coordinations for veterans, service members, and their families. We've seen a 51% increase from baseline of veterans served each quarter since project implementation. This crisis also involves our youth. The pandemic was mentioned as a creator of isolation. We found that 36% of our adolescent admissions are identified as at risk for suicide or self-harm. 35% from the same demographic report that social media is a negative factor in relationship to their mental wellness. In response, we've started a robust school-based program that serves 10 different districts in our area so that we can move our staff beyond the walls of our clinic. We anticipate continued growth in our youth services. In addition, we have created special program targeting at-risk adults for both legal issues and homelessness. This program is known as the ACT, or Assertive Community Treatment Program. It's provided a crucial relief valve to law enforcement and emergency services. Initial outcome shows that 80% of the population has avoided homelessness, and 76% have avoided new legal incidents based on quarterly tracking data. In addition, we've developed a special program in partnership with law enforcement. We have 4 co-responders and 25 iPad devices deployed to our law enforcement partners to increase connection to law enforcement and emergency services. The CCBHC model increases access to care. Since implementation, our Fort County provides 70% of the admissions on the same day that individuals seek services. For those who elect to wait, the average wait time is 3 days compared to the national average of 48 days. They also receive enhanced care coordination and involvement with primary care. If they don't have a primary care provider, we work hard to get them connected. The next big thing in our field is mobile crisis services, which we need to develop in partnership with the new 988 crisis hotline. National data indicates that this CCBHC model reduces ER visits by 68%. It also emphasizes care coordination and improved partnership with our local emergency hospitals. In conclusion, I just want to express my sincere support that we should move this model beyond a demonstration project and have it become a staple of our healthcare system. Thank you for the opportunity to testify here today on behalf of the people we serve and for the incredible workforce. Senator Markey, you said heroes a while ago. There are so many unsung heroes that do this work, and I'm thankful to be in this field. Thank you.
Thank you, Mr. Denny, so much. And going to recognize Senator Tuberville for an introduction of Dr. Taylor. Dr. Taylor is President-elect of the American Society of Addiction Medicine, triple board certified in general, child, adolescent, and addiction and sports psychiatry. And Dr. Taylor also serves as the medical director of the NBA. Senator Tuberville.
Thank you, Senator Markey and Senator Marshall, for having this. Just a quick statement, and I know I'm not a member of this committee, but I will say this is the importance of this committee. I dealt with hundreds of families every year in my former job, and there wasn't many families that I'd ever run into that didn't have some type of mental health problem in their family. This is not a crisis. This is a national emergency. I don't think we really understand the problems that we have now. We're going to continue to have, it's going to get worse if we don't address it, and it's by having hearings like this. I tell people all the time, they say, wait, we can't afford to attack mental health problems. It's too big. My comment to that is we can't afford not to fund mental health in this country. We have to attack mental health in this country, and we've got to fund it no matter what it takes. So tough times requires tough leaders. Dr. Taylor, it's my privilege to introduce Stephen Taylor from Birmingham, Alabama. He's completing his 13th season as the medical director of the Player Assistance and Anti-Drug Program of the NBA and National Basketball Players Association. He also serves as the Chief Medical Officer of the Behavioral Health Division of Pathway Healthcare, a company that operates 17 outpatient addiction treatment offices spread throughout the South. Additionally, Dr. Taylor is President-elect of the American Society of Addiction Medicine. Dr. Taylor is uniquely positioned to understand the scope and the extent of the mental health crisis and emergency we're experiencing in this country. This crisis affects children and adults of all ages and all walks of life. He is the perfect witness for today's hearing. A crisis in mental health and emergency substance use disorder care. He will discuss the work that needs to be done to fix our broken mental health care infrastructure in this country. I'm incredibly proud to have someone like Dr. Taylor working on these issues in the great state of Alabama, and I look forward to partnering with him moving forward to help keep up these efforts. I'm also pleased that this subcommittee is focusing on this today and hope that the entire HELP committee can understand the importance of this. So Dr. Taylor, welcome, and thank you, Mr. Chair.
No, thank you, Senator, and you're recognized whenever you're comfortable, Dr. Taylor. Please begin.
Thank you for that kind introduction, Senator Tuberville, Chairman Markey, Ranking Member Marshall, and esteemed members of this subcommittee. Thank you for inviting me to participate in today's hearing on closing gaps in access to mental health and substance use disorder care by bringing that care into communities across this nation. Today, I'm testifying in my capacity as President-elect of the American Society of Addiction Medicine, known as ASAM. ASAM is a national medical society representing over 7,000 physicians and other clinicians who specialize in the prevention and treatment of addiction and co-occurring conditions. I would like to begin by recognizing the bipartisan work that Congress has done over the years to help address what is turning out to be the deadliest addiction and overdose crisis in American history. Thank you for your efforts. Still, at a time of elevated death rates and medical complications associated with synthetic opioids like fentanyl, psychostimulants like methamphetamine, and the non-opioid veterinary tranquilizer xylazine, much more work needs to be done to create a sustainable and robust addiction care infrastructure, one that addresses addiction as a preventable and treatable chronic medical disease. Accordingly, ASAM asks this subcommittee to focus on 3 areas that are ripe for policy intervention. First, the addiction specialist physician workforce. ASAM estimates that there are only about 7,000 addiction specialist physicians, defined as physicians who are board certified in addiction medicine or addiction psychiatry in this country. While addiction treatment in the United States is often delivered to patients by multidisciplinary healthcare teams that work to address patients' biopsychosocial needs, the distinct clinical knowledge and skill set of addiction specialist physicians best situate us to lead those teams. Addiction specialist physicians can increase a healthcare team's capacity to prevent and treat more complicated medical cases involving substance use disorder. Addiction specialist-led care teams also lead to the greater integration of addiction care into general medical and mental health treatment settings. Even more importantly, such care models can enable our healthcare system to increase its capacity to provide addiction treatment in primary care settings, which is especially important in areas where there is a dearth of specialty addiction treatment facilities. For this and other reasons, Congress created the groundbreaking Substance Use Disorder Treatment and Recovery Loan Repayment Program, or STAR-LRP, in the Support Act of 2018. When individuals pursue a full-time job to provide addiction treatment in high-need geographic areas, HRSA's STAR-LRP can help them repay up to $250,000 in their student loans. Demand for this program has been overwhelming. Therefore, ASAM strongly supports the Substance Use Disorder Treatment and Recovery Loan Repayment Program Reauthorization Act of 2023, which was introduced yesterday in the House on a bipartisan basis and would further strengthen the program while preserving its focus on addiction care workforce. Additionally, ASAM urges this Congress to pass legislation to encourage teaching health center graduate medical education program applicants to sponsor addiction medicine fellowship programs and to require all HRSA-funded health centers to offer addiction and mental health services. Second, decriminalization of the prescribing of methadone for the treatment of OUD by addiction specialist physicians for dispensing at pharmacies. While ASAM is grateful for SAMHSA's ongoing efforts to update federal regulations governing opioid treatment programs, known as OTPs, continuing to restrict patient access to methadone for OUD to OTP settings is a public health threat that unnecessarily limits access to this life-saving medication for those who need it. Therefore, ASAM strongly supports passage of the bipartisan and bicameral Modernizing Opioid Treatment Access Act, which would responsibly expand access to methadone treatment for OUDs by decriminalizing its prescribing by addiction specialist physicians for dispensing at pharmacies. Third, enforcement of federal mental health and addiction parity law. It has been well documented that we need better enforcement of federal mental health and addiction parity law in this country. Under current law, the U.S. Department of Labor lacks the authority to assess civil monetary penalties for violations of federal parity law already on the books. This prevents DOL from effectively ending parity violations with respect to group health plans. That is why ASAM strongly supports the soon-to-be-introduced Parity Enforcement Act, which would finally add civil monetary penalty authority to the DOL's oversight. In conclusion, these policies and resources are imperative to bringing addiction care into communities across this nation and to saving more lives. Thank you, and I look forward to answering your questions.
Thank you, Doctor, so much. And our final witness is Dr. Warren Ng. Dr. Ng is the president of the American Academy of Child and Adolescent Psychiatry and a professor of psychiatry at Columbia University Medical Center in New York City. At the American Psychiatric Association, he served on the Council for Children, Adolescents, and their Families. Dr. Ng, welcome. Whenever you're ready, please begin.
Good morning. Thank you, Chairman Markey and Ranking Member Marshall, as well as members of the Senate HELP Subcommittee. The members of the American Academy of Child and Adolescent Psychiatry, or ACAP, thank you for hosting this hearing, as well as the opportunity to share our thoughts on how to bridge the gap to access to care, particularly for pediatric mental health and substance use treatment. ACAP represents over 10,000 child and adolescent psychiatrists and trainees, all of whom grasp the gravity of the current situation of the pediatric mental health crisis. Our members work in every child-facing system of care in rural and urban communities, as well as hospitals to schools to families and communities across our country. No one in our nation has been spared the impact of the COVID-19 pandemic. Child and adolescent psychiatrists with their teams have been on the front lines. That's the reason why in October of 2021, the American Academy of Child and Adolescent Psychiatry with the American Academy of Pediatrics and the Children's Hospital Association declared a national state of emergency for children's mental health. While there are many factors that contribute to poor access to pediatric mental health care, my testimony today will focus on the impact of the insufficient behavioral health workforce on access to care, as well as some potential solutions. There's been a silent pandemic of pediatric mental health building for decades. This has largely impacted minoritized groups, including racial, ethnic, as well as gender diverse youth, as well as those youth living in poverty. The social disruptions, fear, and grief caused by COVID-19 has turned the world upside down for all children, especially those most vulnerable. The escalating rates of pediatric suicide, as well as mental illnesses, compounded by the chronic workforce shortages, are well documented. We, in collaboration with the federal and state policymakers, must support immediate, short, and long-term strategies. In the short term, to increase access, we can extend the reach of child and adolescent psychiatry workforce by supporting primary care and school-based providers in their settings. Pediatric mental health care access programs, as well as school-based mental health programs, integrated behavioral health, as well as primary care partnership and telepsychiatry have all increased access to care. ACAP is grateful for the recent congressional investments in these models and urges Congress to promote state financing innovations and provider adoption to ensure these models are sustainable. We must meet children where they're at and reduce the barriers to care. We can also supplement our physician supply by recognizing the invaluable contributions of our international medical graduates. These American-trained physician experts are an important part of the mental health care teams, particularly in underserved areas. Long-term strategies to address access gaps must include building a strong pipeline of pediatric mental health providers. There are significant workforce shortages even before the pandemic. This was especially true for child and adolescent psychiatrists, whose educational requirements as physician subspecialists are extensive and costly. Targeted student loan repayment programs and programs that defer student loan payments interest-free while training make a difference. Research has shown that these solutions directly influence physician practice choices. The field of behavioral health will not attract qualified, highly trained providers, reduce stigma, nor accommodate the growing demand until it is on equal footing with physical health and surgical care. Poor reimbursement is a disincentive to recruiting medical students into psychiatry and building robust behavioral health services. This contributes to limited in-network psychiatry access, longer wait times, higher expenses for patients who are forced to go out of network to find any care. So full parity for insurance coverage and reimbursement rates for mental health and substance use treatment are critical. ACAP also recommends the Centers for Medicare and Medicaid Services and other insurance regulators require health plans to use nationally recognized service intensity tools to making medical necessity determinations. These standardized assessment tools determine the appropriate level of service intensity needed for the particular patient and could assist payers in making appropriate coverage determinations. Lastly, we must acknowledge that America is becoming more racially and ethnically diverse and requires a pediatric mental health care system that reflects the communities being served. The COVID-19 pandemic and pre-existing disparities for minoritized youth, including gaps in access to high-quality care, truly, to bridge this gap in all access to care, we need a workforce that reflects the patient's experiences, language, and background. This leads to better outcomes, overcoming stigma, as well as addressing inequities. We can do this by investing in recruitment, training, and broader distribution of a more diverse representative workforce. ACAP encourages Congress to support programs that improve health equity by providing support for training to racially ethnic diverse pediatric behavioral health professionals through scholarship, tuition assistance, as well as professional development opportunities. Thank you again for this opportunity to testify. ACAP is grateful for this opportunity to give input into closing the gap in access for life-saving behavioral health care for children and all Americans. Thank you for taking care of being our heroes as well as our angels in terms of taking care of our children. Thank you.
Thank you, Dr. Ng, very much. Now we'll turn to questions from the senators. Dr. Taylor, thank you for raising the Modernization of Opioid Treatment Access Act. Methadone for chronic pain can be prescribed by doctors and picked up at a pharmacy, but methadone for opioid use disorder, it has a stigma, it's restricted. You talked about SAMHSA and ensuring that we decriminalize methadone as a treatment. Can you talk about why that is such an important step for our country to take?
Absolutely, Senator. As you know, that methadone is the only full agonist opioid treatment for opioid medication that is FDA approved for treatment of patients with opioid use disorder. It seems strange, to say the least, to put it mildly, that I, as an addiction specialist physician, board certified in addiction medicine and addiction psychiatry, would be committing a crime to prescribe a patient methadone in my office who needs methadone for treatment and stabilization of their opioid use disorder. But someone who has no training in addiction treatment, a doctor who is maybe a general family medicine physician or someone in some other specialty, as long as they have a DEA registration, can prescribe methadone in their office for pain, and can do so and have that patient go pick up that medication in a pharmacy. That does not make sense, to be honest, and that is a remnant of a really stigmatizing approach to the treatment of people with opioid use disorder. That's really the only way to understand how that came about. And so what we are trying to advocate for, and what we hope Congress will pass with the Modernizing Opioid Treatment Access Act, is to make it so that we can be very thoughtful and very careful in our approach to prescribing methadone for treatment of patients with OUD. So that it's addiction specialist physicians, defined as someone who is board certified in addiction medicine or addiction psychiatry, who can prescribe the medication in a patient in our office or in one of the other various settings in which addiction specialist physicians work. Some of those settings are actually even more carefully monitored than OTPs, so-called methadone clinics, but can prescribe to patients and then have those patients pick up that medication in a pharmacy. It just increases access to care at a time when, as was mentioned, 106,000 people died last year from overdoses. We have to increase access to care.
Thank you, Dr. Taylor, and I wanted, with the unanimous consent, enter into the record 2 letters from 94 supporting organizations and other clinicians supporting expanding access to methadone and to pass the Modernizing Opioid Treatment Access Act. So without objection, so ordered. Social media, its role in creating this teenage, young people mental health crisis in our country. Love to hear any of you step up and speak about this and what you believe the correlation is. Dr. Chelli, would you like to take that on?
Sure. This one hits close to home as I have 2 teenagers and a preteen at home. But I think what we have observed is that social media distracts children. It's extraordinarily appealing and gives instant gratification for the desire to connect with somebody. Now, this was happening prior to the pandemic, but of course, during the pandemic, in a time where children were isolated, had to remain at home, in many cases were not in their school settings, they were not practicing social skills. And so it's much, the anecdotes that I will hear in the office or from behavioral health clinicians who are seeing teens where I work is that, it takes 1 second for a child to put in friend into some sort of platform where they can connect with other peers, and instantly friends come up and they begin to connect. But these are not actual practiced social skills sort of relationships. And what I think is appealing is that it's so instant, and it can be very engrossing. As a result, the adolescents and children are feeling more isolated. And in fact, we call these social skills because they're skills that need to be practiced. And so I think this is impacting how our children are, whether or not they're connecting with their peers and how they're feeling about themselves.
Thank you, Doctor, so much. Yeah, it's unbelievable. 1 in 3 teenage girls contemplated suicide last year. 1 in 10 teenage girls attempted suicide last year. 1 in 5 LGBTQ youth attempted suicide last year. Social media is implicated. It's an accessory to this tragedy that we're seeing in our country, and we have to do something. We need a teenage privacy bill of rights online. We just have to pass one this year. It's urgent. Thank you. Senator Marshall.
Thank you again, Chairman. Mr. Denny, I want you to talk just a second about your mobile crisis center. As I travel around the state of Kansas, I think I've been in every hospital. The emergency room is the epicenter of the crisis, and the mental health epidemic has definitely impacted that. The National Nurses Organization in my office 2 weeks ago concerned about the violence in the emergency room. There's a right place, there's a tough place to take care of folks with mental health crisis going on, but it's tough in the emergency room. ER docs are leaving the field. We're not getting new ER docs to go into the field. How have you interacted with your emergency room, and what does your mobile crisis center do?
Well, our mobile crisis services, to a degree, have always been mobile. We're now taking it to 2.0 in terms of being able to respond to anywhere in the community. One strategy is to divert crisis in someone's home or a school or another location so they do not end up in the emergency room. That's one of the big strategies that we'll employ. Stabilization during a wait for a placement in inpatient hospitalization is an adaptive challenge. And what I mean by that is that there's no technical fix that's going to immediately resolve this issue. But what we've found, first of all, is partnership on the front end with our emergency rooms. And we serve a rural area, so getting to know and having plans on how we deal with emergency situations are important. Training for emergency room staff is important, at least some base level behavioral health response training. There's different options out there. And lastly, one of the things we've developed in Kansas, or we're still developing, are the regional crisis centers, which would provide an alternative for someone to go and wait and be assessed and stabilize versus an emergency room. And anytime we can find a different setting to accomplish that purpose that's not as triggering or as difficult as an emergency room, I think the more of that we can do, that's a state program with federal support, but the more of that we can do, the less of those incidents we'll see over time. But it is a challenge, it's a frustration. It takes partnership between both of our systems to work through those issues.
Certainly a patient waiting days in an isolated room in the emergency room is not the solution, and exactly. It takes one-on-one nursing staff, so it takes away resources. And we literally just have a shortage of those inpatient opportunities. Maybe to kind of turn, Dr. Ng, tell us what's working, what's not working out there in your world. Just take like 1 minute to tell me what you think is cutting edge and what do you think we've been doing that's not working.
Thank you very much, Senator Marshall. I think that what's working and what's not working is also acknowledging, I think what Mr. Denny mentioned, is really creating that better continuum of care that goes from community to more intensive treatment, whether or not that's emergency department or inpatient psychiatric units. I think what's really important to hold center is the fact that that person who's experiencing that mental health or emotional crisis is probably scared and frightened and overwhelmed as well. So being able to center our experience with that person is also understanding that emergency departments are never the place to be when you're in that situation. And how do we humanize that environment, whether or not this is an adult or as a child or a family member? So I think that creating that continuum of care, of the escalating intensity of outpatient and community services that are embedded within communities, partnering with communities to provide the most culturally competent as well as responsive care is really important. I think that means that we have to create some innovative programs that are funded and sustainable so that we can provide wraparound care for young people and their families and adults within communities. I think that we're thinking about these intensive outpatient programs, partial hospitalization, wraparound, as well as some of the critical time intervention programs that can sometimes be helpful. But I think the important thing is that they're networked towards a system of care that is a continuum so that people who are experiencing that care don't have to jump through hoops, but experience it as being surrounded by people who can provide the care they need.
Yeah, thank you so much. Mr. Chairman, I'll yield back and maybe we can get some follow-up questions after our colleagues finish.
Absolutely. Senator Baldwin.
Thank you, Mr. Chairman, Ranking Member, for holding this important subcommittee hearing, and thank you to all of our witnesses today. I will never forget meeting with 3 moms in my office who all lost their children to fentanyl overdoses. Poisonings is the word they used, I think in part because they believe their children perhaps didn't know that there was fentanyl lacing the illegal pill that they had taken. It's so clear that we have to do more to stop fentanyl from coming into our country and our communities and increase prevention and treatment efforts and make overdose reversal drugs much more widely available. To do so, we have to use every tool we have to combat this epidemic. And I know as chair of the LHHS subcommittee of appropriations, I'm committed to fighting for sufficient resources. I'm also proud to co-sponsor Bruce's Law with my colleague, Senator Murkowski, who has led that important measure. It would bolster federal prevention and education efforts surrounding fentanyl. I look at how the opioid epidemic has changed and evolved, if that's the word you want to use, but changed fundamentally just in the last decade or so. And so, Dr. Taylor, maybe you can describe why the fentanyl phase of this crisis has proven to be so especially challenging for healthcare providers. How have you experienced this, this transformation or evolution in our opioid epidemic in the country?
Thank you for that question, Senator Baldwin. So you hit something right on the head, which is fentanyl represents a third phase of this opioid crisis. Sort of the first phase was the prescription opioid proliferation and the overdose death and the addiction epidemic that resulted from that. Second phase being heroin, as prescription opioids were made more difficult to access and much more expensive, and heroin came in and was much cheaper and much more readily accessible. Well, one of the challenges is that fentanyl is even cheaper than heroin. And so as people developed ongoing addiction, marked, of course, with particularly with opioids, with the development of tolerance to whatever dose of drug that they were taking, and withdrawal, which is incredibly unpleasant when someone attempts to abruptly stop using opioids. Then the person is driven to find something else that they can take. And of course, with fentanyl being less expensive and more readily available, it was predictable, if you think about it, that people would then turn to fentanyl. The problem is that it wasn't just pharmaceutical fentanyl. When you think of fentanyl, it's important to recognize there's pharmaceutical fentanyl, and then there's the illicitly manufactured synthetic product. And then beyond that, there's a number of different synthetic fentanyl analogs that are even more potent than fentanyl. And so people are familiar with the word carfentanil, which is an analog, a synthetic analog of fentanyl that has been used to put down elephants. I mean, that's how potent that drug is. And that's the drug that you hear people, first responders showing up in situations and just by casual contact with it, ending up with significant levels of it in their system. So part of the challenge is that as people have continued on with addiction, that may have started from the time they were on prescription opioids, they now are at a point where they are addicted to fentanyl. The other part of the challenge for us as addiction treatment professionals is that because fentanyl and its analogs are so incredibly potent, it's actually much harder to provide treatment for someone who is addicted to fentanyl. And we literally now are scrambling. ASAM just had our annual meeting a couple of weeks back, or actually about a month ago, right here in the DC area. And we literally had several conferences with people on the front lines sharing with our general membership what are the strategies for taking someone who is addicted to fentanyl or even one of the more potent fentanyl analogs and trying to get that person inducted onto buprenorphine or even methadone, because the challenge is that the withdrawal syndrome is so severe when we try to transition a person that very often people end up not continuing with the treatment and going back out to use fentanyl. And so we've had to figure out, and we're actively working on strategies that work to address the severe withdrawal that people go through so long enough so that they can transition smoothly to a medication like buprenorphine or methadone, which is why we are pushing to make it possible for us to be able to prescribe methadone and have people get it from pharmacies, because for many patients, buprenorphine isn't the medicine that they're going to need for that transition. It's methadone. And we need to have every tool available in the toolbox to be able to take care of people, particularly because of this extremely complicated, potent drug to which so many people are addicted.
Thank you.
Senator Murkowski.
Thank you, Mr. Chairman. And I want to thank my colleague for your support on Bruce's Law. I think, Dr. Taylor, this goes exactly to what you're talking about, is the intensity of the addiction. For those that have been using, whether it was prescription drugs or heroin, the intensity of the addiction is such that I think people need to understand that we're dealing with something at a higher, more intense level, and what that actually means, and the intensity of fentanyl itself and the lethality. And so as we work to educate people, to try to explain that this is not something that you can engage in lightly, you will be poisoned and you will die. And part of what I'm hearing with fentanyl is that the treatment, as you have indicated, is very, very challenged, but that the likelihood of being poisoned, as Sandy Snodgrass's son Bruce was, is out there as a very real reality. So the lethality of fentanyl is something that scares the living daylights out of me. I want to ask, and I'm not entirely sure who to address this to, but this week in our largest newspaper in the state was a front page article about traumatic brain injury and how Alaska has the highest rates of TBI deaths, related deaths in the country. 1 out of every 4 deaths in Alaska under the age of 30 is related to TBI. So we know that we do a lot of rock climbing and some things that are inherently dangerous, four-wheeling, snow machining, we get all that, but the reality is of those deaths, 43% were due to suicide. Suicide attempts are more common in individuals that have sustained a brain injury, almost half of brain injury survivors reporting symptoms of depression. So the question to you all is what protocols are in place to ensure that those who have sustained a TBI get the mental health that they need, that they get it on the front end? We recognize that this is a pretty tight correlation here. Are we doing anything with regards to that? If you've had a traumatic brain injury, is there follow-up then to help on the mental health side? Dr. Ng?
Thank you, Senator Murkowski. I think that this is a really incredibly important question to ask around how are we integrating mental health and behavioral health and suicide screening throughout all of our healthcare systems. And it's really understanding that there's no health without mental health. And it's being able to ask those questions, but also work collaboratively with teams. So when we integrate mental health and behavioral health services within medical settings and primary care settings and specialty pediatric settings, it's really important. It allows us to have that conversation, to ask those questions, but also when there are issues related to suicide, that we're able to address it directly and we're not having to refer to someone else, but when you're talking within your trusted medical care team and you're able to provide that level of identification, screening, assessment, and referral to treatment, I think that that's really key.
So Dr. Ng, let me ask about that because part of our big challenge in Alaska is lack of access to the providers, and particularly pediatric health providers who would be encouraged to practice in rural and medically underserved communities. Senator Smith and I have a bill, the Mental Health Professionals Workforce Shortage Loan Repayment Act, again designed to get professionals out into rural areas. But it is a challenge for us in Alaska, I know, but I know that it's also equally challenging in other parts of rural America. I don't know that we can do enough fast enough, and particularly when we're looking at suicide statistics for young people who are struggling and are just simply not able to get the mental health treatment that they need. In Alaska, unfortunately, if a young person has been told that we don't have any services that we can provide to you, the care that they receive is outside. And when I say outside, it's not outside of a building, it's outside the state of Alaska. So they have to fly to Seattle if they're lucky. A lot of times the medical help is available in Utah. You're separated from your family, from your support systems. This is not a tenable situation. And so I look at what we need to do to grow this workforce, but I also think that Dr. Ng, you talk about this continuum of care and wraparound services, what more we can do to help parents and families and educators and local community leaders to help be that support in these smaller communities until you can get to the medical professional. I don't know if there's a question in there, but we're really struggling with this at home. Dr. Ng?
Thank you, Senator. I think that, thank you very much for your leadership and support for S462, because I think the workforce shortage issues are really key, but also being able to fund and support providers to be able to provide those mental health services within the medical setting and within communities is also really key. So being able to finance some of those strategies. There's the Pediatric Mental Health Care Access Programs that provides consultation to medical providers, particularly pediatric providers in urgent settings. The other thing is telepsychiatry has been really important to be able to bridge some of those gaps. I think that that partnership with families within communities is key so that we can also encourage telepsychiatry to be able to be helpful to bring in key members of the community as well as family members to be a partner to that care. I totally agree that there isn't a quick fix to this because this problem existed well before, but at the same time, the loan repayment as well as trying to finance integrated behavioral health interventions as well as leveraging telepsychiatry and continuing to fund those innovations that have been helpful during the pandemic would be key.
Thank you. So, thank you. Senator from Colorado.
Thank you, Mr. Chair, and thank all of you for being here today, but also for your ongoing work. Clearly, a very, very important time to address some of these issues. Peer-to-peer mental health programs are taking off across school districts around the country. These programs where trained students offer a listening ear to their peers. They look for concerning signs, help connect students with professional resources, appear to add real value. Students often feel more comfortable asking for help from a peer than from an adult, and this step alone can help break the stigma, especially for young people, around going forward and seeking care. So, Dr. Ng, why don't I start with you and just say, why do you think so many schools are gravitating, or I mean, beyond that, trying to work around the stigma, why are they gravitating towards these peer-to-peer programs, and what more can we do to support them?
Thank you, Senator Hickenlooper. I think that's really key perspective is really bringing in the youth voice as well as the youth involvement and the youth solutions. I think that they're incredibly creative and they're also an incredible resource for us to continue to partner with. And that's partnering with them at a level that respects the information that they're giving us. So I think it's really important that we honor that. And also the diversity among the youth perspectives. And as you heard, the number of adolescent females that are experiencing helplessness and the rates of suicide with regards to their LGBTQ and gender diverse youth, as well as racial and ethnic diverse youth as well. I think that having the youth voice, and the youth is definitely, they will connect with each other in a way that we are not easily connected to them, and we can also gain from them that wisdom. But the important thing is that that's not where we stop, that's where we start. Where we need to end up is actually connecting those youth peers as well as those support services with other additional help and services along a larger continuum. So being able to reinforce the school-based mental health programs embedded within those, as well as crisis response, so that those young people who need more urgent and critical care can be coordinated through that system, through their youth advocates.
Great, appreciate it. Mr. Denny, your approach is from a different ecosystem. You agree with that?
Yes, especially in relation to the development of peer services. That's one of the 9 required services under CCBHC. Peer and family support services at our organization. We've hired our first peer services supervisor, and our hope is to continue to develop those services. And one of the exciting things in Kansas, too, is we've just recently passed a code that would allow us to provide parent peer support services for parents of youth in our services. And I'm really excited to see those develop. But it's, as it was addressed earlier, there's not always a provider nearby. So our need to identify across multiple areas, whether it be schools, hospitals, there's a lot of different community-based trainings to help identify people in need, and not always rely on a service provider to be there, because a lot of times when the crisis happens, the behavioral health professional is not right around the corner. So programs such as mental health first aid, psychological first aid, question, persuade, refer, QPR training. There's a lot of different models that help train the community and engage around suicide, particularly in rural areas where we don't always have someone readily available. We don't have to go to Seattle, but we're 2.5 hours away sometimes from a hospital. So I totally get the isolation and what do we do when we're here, kind of out here on our own.
Great, thank you. Dr. Chelli, I was going to, Colorado hospitals often don't have the resources to provide the care that for kids, just as Mr. Denny was describing. Hospital staff trying to do too much with too little, and again, especially in rural areas. Your testimony highlighted the outsized importance of community health centers, I think, in this community health programs, but not just, but centers and programs. What do community health centers and certified community behavioral health clinics do to help address these gaps in the behavioral health care system, and how do we, how can we do more since there are still so many people struggling to access care?
Thank you so much, Senator Hickenlooper, for the question. So one of the cornerstones of community health centers is that all of the services are within the same team. That team can be very large, thousands of staff, but they're all within the same team. And that makes coordination of care, as Dr. Eng was referring to, much greater. And I did want to highlight for a moment around pediatrics. At Brockton Neighborhood Health Center, we have the good fortune of having a program that's called a grant-funded initiative that trains not only the behavioral health provider, so you could have a behavioral health provider who maybe had worked more with adults but is able to get trained in working with children because there's such a gap in services for pediatrics of trained professionals. This program trains providers on the medical side, medical assistants, nurses, behavioral health clinicians, clinical secretaries, everybody who's on the team on how to create that space that really engages both the child and the family. And in some cases, other community members as well.
Yeah, I love that approach. I think that's very useful. Thank you all. Dr. Taylor, I've got questions for you. Yield back to the chair.
Thank you, Senator, so much. I'd just like to follow up, if I could, on Senator Murkowski's line of questioning. With so few practitioners, how can telehealth help deliver services? What is necessary to be able to bridge this gap between Anchorage and Seattle or Salt Lake City? What are the reimbursement issues? What are the licensing issues so that people can practice across state lines virtually? What are those new licensing opportunities that are going to have to be put in place if we're going to ensure that we get the resources to where the problem is? Yeah, Dr. Ng?
I'll give it a try. I think that there are multiple strategies. I think one of it is the state compacts and being able to provide regional support. I think that familiarity for a child and adolescent psychiatrist consultant to know that system of care, to understand that community being served is really key until the time that you can develop in resources. So specialists who are actually embedded within, for Senator Murkowski, within the state of Alaska. And really being able to partner with the local resources, with the community health centers, with the CCBHCs, with that network of care and the educational system is key. Also being able to finance appropriate consultation when we're providing that expertise as child and adolescent psychiatrists and physician experts in mental health. One of the things that we do are able to integrate is the health as well as the mental health as well as the psychosocial issues. And so being able to integrate all of those in terms of a comprehensive treatment plan involving all members as well as the youth, the family, the community, and the school resources is really key.
So how will that help Senator Murkowski's problem up in Alaska? Do you have a recommendation in terms of ensuring, that somebody doesn't have to leave Anchorage, can get a top-notch psychiatrist in another state online so that it can be integrated with perhaps the physical care in Anchorage? What's your recommendation?
So, those wonderful programs, the Pediatric Mental Health Care Access Programs, which really helps to partner child and adolescent psychiatrists with pediatricians, if we're talking about that population, it's really helping them talk through the care of that young person to develop and acquire some of the skills and the tools necessary to providing that care on site. And it's really building that capacity for the care. There are other models such as the ECHO models that can help extend the clinical expertise locally, whether or not it's with a primary care provider or if it's a provider within a CCBHC or a community health center or a private practice provider as well. So I think that is the most rapid way of expanding your current short-term strategy in addition to building some long-term strategies.
Yeah, and Dr. Taylor, I'd like to come back to you one more time, and that's on this Suboxone, methadone issue in terms of the help which people need. Can you just, put a exclamation point on the need for that law to change?
Senator, I have about 3 months ago, I got a message on LinkedIn from a gentleman who was the father of a young man who had been a patient of mine. And the message was thanking me for helping his son and letting me know that his son was just about to graduate from law school. His son had been a patient of mine with a severe opioid use disorder. And I took care of him in my office for several years when he had flunked out of college and had gone through the progression, very much like I described previously, of addiction to prescription opioids, and then had moved on to snorting heroin and then injecting heroin, and had really severe addiction to opioids. And I worked with him in the office, and I treated him with buprenorphine, and he did well for periods of time and then would have a recurrence of his illness. And then I, at one point, had to refer him to a methadone program, an OTP, because I was not able to provide that for him in my office. And so during that period of time, I stayed in touch with him, and I tried to liaison with the doctor at the methadone program, who was not necessarily an addiction specialist, but we made the best of it. And then at other periods of time, we then transitioned him back to buprenorphine, and I was able to then be the one prescribing and monitoring his medication. It was a tortuous process taking care of that young man because of the fact that he wasn't able to just have me work with him on a consistent basis, prescribing whatever it was that he needed, that I, as an addiction specialist, was more than qualified to prescribe him. The bottom line is, so he had to come and see me for a while and then go to the OTP for a while and then come back into my office for a while. And it was a very difficult treatment course. I can't guarantee that he would have had a shorter or easier time of it if I had been able to prescribe him the methadone the same way I was able to prescribe him buprenorphine. But it certainly would have made more sense for him, and it would have been more convenient for his family. Thankfully, he's in recovery now. He's doing great. He just graduated from law school. But it shouldn't be necessary for him to go through all of that, and not everyone has the kind of outcome he had.
Senator Marshall.
Thank you again, Mr. Chairman. Mr. Denny, you've led this prototype of the Certified Community Behavioral Health Clinics. What are the 3 most important lessons that you would pass on if we were going to set something like this up in Alaska or other parts of Kansas? What's the secret recipe in your opinion? Lessons learned.
And Raina from the National Council was just letting me know there are 2 clinics being piloted in Alaska currently, 2 CCBHC clinics. So that model is off the ground there.
That's great. And we should ask the Senator Murkowski's staff to follow up with you in the clinics and share some lessons learned.
Yeah. In terms of setting it up, it is so important to have an effective community needs assessment and make sure that you're really assessing the needs of each community served. You know, the accessibility conversation, particularly as it relates to telehealth, I always think about rural frontier areas, right? And a lot of our areas that we serve don't necessarily have connectivity. So making sure that wherever we offer those services have the tools and resources, that the right people are at the table. So an effective needs assessment that truly identifies the unique needs of each community. The second thing is really developing providers' skill sets and practices that are going to have outcomes. So the models you choose need to be applicable to the populations you're serving. And I think Kansas has done a really good job of choosing evidence-based practices that are really relevant to the needs of Kansans we are serving. And the third thing is, and this is a practical thing, but there is a lot of talented CCBHC clinics throughout our country. When we were starting, I had people from all over the country reaching out to me saying, try this, try that, consider this, consider that. Here's how you get started on your data. But thinking of a data collection strategy that's practical, meaning that you can get started with meaningful outcomes that are going to tell your story, but at the same time having a plan to how to build and grow that. You know, in Kansas, in the next 6 months to a year, we will have a data warehouse that will allow us to track outcomes across our entire state population. That'll be a really unique opportunity to begin observing how we are using these clinics to truly impact change.
Thank you. Dr. Taylor, I know you're a treatment specialist, but I want to go to the prevention side for a second. You know, as a physician, we take family histories. You say, oh my goodness, you're at risk for colon cancer, so therefore you need to start your screening at an earlier age, or you're at risk for diabetes. Oh, and your weight's up a little bit this year and your blood pressure's up. How are we doing on identifying at-risk people? And what other ounces of prevention would you be recommending out there from your experiences?
Thanks for that question, Senator Marshall. I'm actually also a big-time prevention hawk. Our organization, ASAM, is very much concerned about prevention as well as treatment. We know what the risk factors are for a young person to develop an addiction disorder. We know that addiction is a disease of pediatric onset, in fact. So we know that effective interventions, and when I say just when I say pediatric onset, we know most of the time when someone develops an addiction disorder, the onset of use and the onset of the disorder is actually in adolescence. So that's what I mean by pediatric onset. But we know that there are effective evidence-based interventions, prevention interventions that work at the community-based level. They often involve building social skills, teaching adolescents to social skills, and many of these are school-based programs. We know that the number one risk factor for a young person to develop an addiction is to have a parent who has or has had an addiction disorder. So one of the most effective things you can do is to provide effective treatment for parents who have an addiction disorder, get them stabilized so that their children are not subject to the ACEs, the adverse childhood experiences that a child of a person with an addiction is at risk for, and then target those young people knowing that they're at increased risk with early intervention. And I've done that on the individual level in my office, but also organizations can do that. And I'm involved in community-based organizations in Birmingham, one specifically called the Addiction Prevention Coalition that actually does a lot of programming in and around Birmingham specifically designed to target young people in schools with mental health first aid, with peer programs like Senator Hickenlooper had described. That is something that is doable. We at ASAM support the implementation of those programs. The key is to fund ones that are evidence-based and to actually de-emphasize and not continue to fund those that have been shown to not be effective.
Well, thanks so much. Again, I want to thank all the witnesses. I think you can tell this is a very thoughtful subcommittee, and your testimony is very valuable. And we hope that there's follow-up at the staff level, and you all certainly made us think about several issues, and I appreciate you being here. Thank you.
Thank you, Senator Marshall. Thanks to our great panel here today. This is obviously a period where there's a devastating behavioral health crisis that threatens every community in this country and disproportionately impacts communities of color and low income and other marginalized communities. Thanks to these experts here today and so many people across the country, we have the opportunity to build on what has already been done to create a society where everyone has a fair and just opportunity to attain their highest level of health. And I look forward to continuing to work with each of you to do that. We have to discuss how we can get more resources into the hands of all of the practitioners, all of the families out there. A vision without funding is an hallucination. If you get the tools, you'll be able to help families. So I ask unanimous consent to enter into the record statements from various stakeholders outlining priorities for closing the gaps in access to mental health and substance use disorder care. And for any senators who wish to ask additional questions, for the record, they will be doing 10 business days on June 1st at 5 p.m. The committee stands adjourned.